Good afternoon, everybody, and welcome to the KISA online webinar presented by one of our Gold Corporate members, SSCM Mthembu Medical. Today's topic will be clinical application of medical ventilators that will be presented by Abdelmalek Rabie from Hamilton Medical. My name is Karel van der Merwe, and I'm the chairman for the Western Cape branch of KISA, and it is my privilege to be your host for today's webinar. Before I introduce Malek, just some information regarding the webinar. Please feel free to make use of the chat box to post some questions during the presentation, and then we will allow some time for Malek to answer those questions at the end. And please ensure that you've got your microphones muted throughout the presentation. Our presenter today is Abdelmalek Rabie. Malek is an experienced biomedical engineer and technical manager with over 15 years of experience in the healthcare industry across Africa and the Middle East. His expertise span across technical support, medical equipment procurement, preventative maintenance, sales, and operations. Rabie has a strong leadership and regulatory compliance, training, and systems integration. He holds a BSc degree in biomedical engineering, as well as an MBA and Microsoft Certified Systems Engineer. He began his journey at the American Hospital in Dubai as the Medical Equipment Procurement Officer from 2010 to 2016, whereafter he became Technical Support Engineer at Hamilton Medical, and since 2020 he is the Technical Manager at Hamilton Medical. Malek exhibits skills in biomedical systems management, technical support and training, medical equipment procurement, project and regulatory compliance, networked healthcare systems, and preventative maintenance. I'm sure you agree with all those credentials. It's time for me to step aside and hand over to Malek. Thank you very much for joining us today. We look forward to your presentation.
Thank you so very much for the introduction, and thanks for everybody for joining in. Actually, I know almost all of you are from a biomedical background, and it's quite challenging to select a topic related to the biomedical technical topic regarding the ventilators, because and the ventilators, different manufacturers have different technical concepts in terms of the oxygen and gas mixing, in terms of the control of flow and the pressure of the ventilator to the patient. So I'm trying to make it more general and focusing on some clinical concepts, because for us as biomedical engineers and technicians, this is very important, as this is the kind of common language between us and the end user, the nurses, RTs, and doctors. So it's very important for us to understand the clinical terminology and concepts when talking about the ventilators. Also try to, of course, involve some technical and electrical points of view when it comes to some kind of gas control, gas mixing, and these things. And the other thing, most of you or some of you might not have experience with the ventilators, or might not have worked on the ventilators before. So I'm trying to make it as basic, as simple as I can, so at least everybody can get something out of it. So let's jump straight to the presentation. So the ventilator is a device that assists the patient in the ventilation, means it can help the patient with the inhalation and the exhalation. This is the basic, simple definition of the ventilator. Okay. So of course, the lung is the organ in our body that does this kind of gas exchange, helps the patient take the oxygen and get rid of the CO2 that results from the mechanism, the gas exchange, or the burning mechanism in our body. If we look at the lung, the total capacity of the lung is around 6 liters, 6,000 millimeters, but we are not using the whole lung capacity for the ventilation, inhalation, and exhalation. Our normal breathing is somewhere here in between 0 and 3,000 milliliters. That's the normal tidal, we call it tidal volume area, where the patient normally inhales and exhales. So normally when we take a breath or we inhale, we're taking something between 400 to 600 milliliters. So I'm not using the whole lung during the ventilation. That's the mechanical ventilation when we are connecting a tube inside the patient trachea and pushing gas inside the lung. This is what the ventilator is going to do. So why we need mechanical ventilation? Simply to deliver oxygen to the patient and to eliminate the carbon dioxide from the patient body. And one more thing is to ease the work of breathing, means if the patient is suffering or finding difficulties in breathing, the ventilator is going to help him with that. Of course, mechanical ventilation has some risks because it's something industrial, it's mechanical, it's not a natural meaning of ventilation. One of the risks is the infection. Of course, when you ventilate a patient, you are putting the trachea inside, the endotracheal tube inside the patient trachea, so you are pushing something inside the patient lung. This means you can transfer bacteria or germs to the patient lung. That is one of the risks. Lung damage, when you apply high pressure to the patient lung, that might damage the lung alveoli. The side effects of medications, because sometimes they're giving medications to the patient to sedate him and make the ventilation easier. Of course, also plus maintenance of life means sometimes he's kind of a patient who is not gonna benefit from the ventilation, but still you are trying to keep him alive. But sometimes the ventilation is useless in some cases. Last, the diaphragm atrophy means the patient diaphragm, when you are relying on the ventilator for a very long time, this means not using this muscle for a long time. This is gonna cause the atrophy for that because of the lack of use of that muscle. Indications of mechanical ventilation when we know that we need to use a ventilator with a patient. Of course, when there is an apnea situation, means the patient is not inhaling or exhaling. Acute lung injury. Low oxygen, when the oxygen concentration in the patient blood is very low, or when the CO2 in the patient blood is very high. This means that we might need an assistant ventilation, means we might need to connect that patient to the ventilator to help him with these circumstances. Respiratory muscle fatigue, coma, airway protection means sometimes we're preventing, when there is a lot of secretions inside the patient trachea, we try to prevent these inflations and bacteria from going inside the lungs. So we put an endotracheal tube inside, and then we inflate one balloon to prevent these germs and bacteria from going inside the lung. Excessive work of breathing, as we said, when the patient is struggling, finding it very hard to inhale or exhale. In this case, we might need to support him with a mechanical ventilator. And during surgical procedures as well, we need to sedate when the patient is sedated, he's paralyzed, he can't, his muscles are relaxed, then we might need to connect him to a ventilator to help him with the ventilation process. Let's come across some of the ventilation terminology, ventilation terms that you can see on the ventilator. Whenever you interact with a mechanical ventilator, you will come across these kind of terms like the airway pressure, P airway. What is the airway pressure? The airway pressure is the pressure on the patient airways, which is measured at the patient's mouth. So it's the pressure that we measure at the patient's mouth during ventilation that we call it a P airway or airway pressure. Alveolar pressure is the pressure inside the patient alveoli. Okay, so this is the one which is inside the lung, not at the patient mouth. Transairway pressure is the pressure difference between the airway pressure and the alveolar pressure. So the P airway is the pressure measured here. The P alveoli is the pressure measured here. The PTA, transairway pressure, is the pressure difference between this one and that one, which is actually the pressure at the patient trachea. The peak inspiratory pressure is the maximum inflation pressure, the maximum pressure that we are giving to the patient. They are pushing inside the patient, that we call it the P airway or peak inspiration or inspiratory pressure. The PEEP stands for positive end expiratory pressure. So as the name suggests, it's a positive pressure at the end of exhalation. So when the patient exhales, the pressure that remains inside the lung after the end of exhalation, we call it PEEP. Okay, the mean airway pressure is the average pressure. So we have the P airway during the patient at the pressure at the patient mouth. At any point, that's the P airway. The PIP is the maximum, but the P mean is the average. Okay. PIP, we have described this. P plateau is the pressure inside the patient airways when there is no flow. So it's similar to the P airway. We measure it at the patient mouth, but we measure it when there is no flow going inside the patient. So like we are stopping the inspiration flow. So that's the P plateau. Okay. So the PT, the difference, the PEP minus P plateau is the PTA, and that's the pressure at the patient trachea, because as we described, the P airway is here, the P alveolar is here. So the pressure difference between this and this is the pressure at the patient airways. So this is how the pressure waveform is gonna look like. Okay, so this is when the patient starts the inhalation. This is the P airway here, the patient pressure inside the patient airways until it reaches to the maximum or peak. That's the PIP. When we stop the flow, that's the P plateau. Okay, when we stop the flow, that's the P plateau, and then doing this, the exhalation, at the end of exhalation, that's the PIP, which this is the PIP, sorry, which is the positive end expiratory pressure. And that's the pressure difference. This is the pressure difference at the patient trachea, the pressure difference between the pressure here and the pressure here. When we come to talking about ventilation and oxygenation, that's two major main definitions or terminology that are widely used. When you talk about ventilation, means getting rid of the CO2, okay, which is the CO2 elimination. You remember when we said the main purpose of the ventilation is to give the patient oxygen and to get rid of the CO2. Getting rid of the CO2, we call it ventilation. And giving the oxygen to the patient, we call it oxygenation. The main parameters that can control the ventilation to the patient is the tidal volume, minute volume, frequency, inspiratory time, expiratory time, and I/to-E ratio. We will come to this after a while. The main things that control the oxygenation to the patient, or another meaning, controlling the oxygen level in the patient blood, is the FiO2 and PEEP. Another important term is the lung compliance. Lung compliance means how the lung is compliant, means how easy it is to put pressure inside inside the lung. So if you need less pressure to inflate the lung, this means the lung is more compliant. If you need more pressure to inflate the lung, it's kind of stiffness in the lung, means the lung is less compliant. Okay, we have two types of compliance. We have the static compliance and we have the dynamic compliance. The static compliance when at one point when there is no flow. So when you are measuring the compliance when there is no flow, that's the static compliance. When you are measuring the compliance with the flow during the gas flow, that's the dynamic compliance. How we calculate the compliance? Compliance is volume by pressure. And it makes sense because, as I said, if you need high pressure to inflate the lung, okay, if you need high pressure to inflate the lung, means the compliance is low, and vice versa. If you need less pressure, this means the compliance is high. The dynamic is the same, but here we are including the flow factor in the equation. So the only difference here is the P plateau, and we said P plateau is the flow when there is no pressure. The pressure is when there is no flow, sorry. So here we don't have a flow here because we are stopping the flow, means that's static, while the PIP is the peak inspiratory pressure. That's the pressure when there is a flow, and that's the dynamic compliance. Resistance is also a very important term, means how resistant is the patient airways to the flow, means if the gas is easily flowing inside the patient lung, this means the resistance is low. If the gas is struggling flowing inside the patient lung, this means the resistance is high. Okay, and the resistance by definition, or the equation is, it is pressure by flow. The resistance is, we are dividing the pressure by flow, that gives you the resistance of the patient airways. So the pressure here is the PIP minus P plateau, because as we said, P plateau means there is no flow, so we need to deduct the P plateau from the peak inspiratory pressure, because if there is no flow, there is no resistance. That's very obvious. If there is no flow, there is no resistance. We know this in the electricity. We know this in the fluid flow. Ohm's law, for example, V is I by R. If there is no I current, there is no V. It's the same here. So we need, if we want to calculate the resistance, we need to know there must be a flow. That's why we need to exclude the P plateau, because P plateau, there is no flow. So we can't put it in the equation. Time constant is a very important factor that we need to calculate. Time constant is the resistance. We are multiplying the resistance by compliance. So we have calculated the compliance. We have calculated the resistance. If we multiply the resistance by compliance, that's gonna give us the time constant. Why we need the time constant? Because this is gonna help us know how much time the patient need to exhale. Because we know in the ventilation, the inhalation is an active process, while the exhalation is a passive process, means we can push pressure inside the patient, we can push flow inside the patient lung, but we can't pull in the normal ventilation. We can't pull the flow from the patient lung. So we have no control over the expiration. So we can't, as I said, control the expiration flow or expiration pressure. Okay. All what we can do is just give the patient enough time to exhale. How we can know how much time the patient needs? We can know this from the time constant. We multiply the resistance by compliance, and then we know how much time does the patient need to exhale. And that makes sense, because if the lung is very compliant, is highly compliant, means it needs more time to empty the lung. And if there is a high resistance to the flow, means we need also more time to allow the gas flow outside the lung. So both factors together, the resistance and compliance, if they are high, means we need more time for the gas to come outside from the lung during exhalation. Just an example, how to calculate, we just multiply the resistance by compliance, and then from that, we can calculate the time constant. Dead space, a very important term as well. Dead space is we remember when we talked about the gas exchange in the patient alveoli. Guys, gas exchange means inside the patient alveoli, the blood is gonna take the oxygen from the alveoli and give the CO2 to the lung. Any part of the whole respiratory system not involved in this process, we call it dead space. Means the volume, the air and the gas inside the patient trachea, inside the patient nose, inside the patient mouth, inside the breathing circuit, all this volume is not involved in the gas exchange process. Means the patient is not benefiting directly from this gas. So we call it dead space. It's not involved anyhow in the gas exchange process, okay? Minute volume, alveolar volume, and dead space. Minute volume is the total volume that goes inside the patient lung in 1 minute, okay? So that's the tidal volume times the frequency. Tidal volume is the amount of volume going inside the patient lung in one breath. When the patient inhales, how much air he is taking, that's the tidal volume, okay? The minute volume is the total volume that the patient is taking over one complete minute. That's why we multiply the tidal volume by the frequency, which is how many breaths has the patient taken in 1 minute, okay? Power source input power, that's in general, some ventilators are pneumatically powered. Some ventilators are electrically powered, means you need AC power to run the ventilator. If they are purely pneumatic, means you just need gas to power the ventilator. You don't need any electricity or power. Some ventilators are, and most of the ventilators that we see are both pneumatically and electrically powered, means you can't run or drive the ventilator without power, AC or battery, and you can't run or use the ventilator without the gas. So it's a mixture of both of them. Okay. So that's in general. Pressure delivery, I'm gonna just go quickly over these slides. We have positive pressure ventilation, we have negative pressure ventilation, and we have combined pressure devices. What that means the way how we are delivering ventilation to the patient. Naturally, the patient inhales because there is a negative pressure. When the diaphragm relaxes, the volume inside the patient chest becomes big. Okay, this means that bigger volume, less pressure, so the pressure outside becomes higher than the pressure inside. That forces the pressure to go inside the patient lung. So that's a negative that's the natural way of ventilation. The way we are doing now in the modern ventilators is the opposite. It's not the negative pressure, it's the positive pressure, means we are pushing the pressure, the gas, from outside to inside. So we are applying positive pressure to the patient, not applying negative pressure inside the patient lung. Okay, that's by the way. So this is the way how the mechanical ventilator works. We are pushing positive pressure inside the patient lung. In the olden days, it was kind of negative pressure, like the patient used to be inside a container or inside a cylinder where we apply negative pressure inside that cylinder, and then that forces the pressure to go inside the patient lung. So that's the old kind of ventilators. There are some kind of combined pressure devices, means positive end pressure, where you are pushing pressure inside and taking pressure outside the patient. So let's come quickly through the ventilation parameters and terminology. The frequency is the frequency, respiratory rate is the number of breaths per minute. The inspiratory time and expiratory time is the TI and TE. So TI is the time the ventilator needs to take a full inhalation breath, and the TE is the time that the patient takes to exhale. The VT is the tidal volume. As we said, that's the amount of the air or gas that goes inside the patient lung in one breath. The minute volume is the total volume that goes inside the patient lung over the complete one minute. So we multiply the frequency by the tidal volume to get the minute volume. Okay. The FiO2 fraction of inspired oxygen, that is the measurement of the oxygen concentration that's going inside the patient. So the oxygen concentration that's delivered by the ventilator is called the FiO2. Naturally is 21% in the air. That's that we naturally inhale. The PEEP is the pressure at the end of the exhalation. So when the patient finishes, ends the exhalation, whatever pressure is left inside his lung, that's the PEEP, positive and expiratory pressure. P airway is the pressure measured at the patient's mouth here. We call it P airway. P plateau is also the pressure measured at the patient's mouth, but when there is no flow. Like the patient inhales, stops, then when you hold the flow, when you stop the flow, that's the P plateau. P max is the maximum pressure. P ramp is how fast, how quick is the pressure is delivered to the patient. Means you can achieve the maximum pressure in 1 second. You can achieve the maximum pressure in 0.1 seconds. So if you achieve the maximum pressure in 0.1 seconds, the ramp is too high. Okay. And the opposite, the more the time you have to achieve your pressure, the ramp is less. Compliance and resistance, and we have seen that the compliance means how compliant the lung is for the inflation, means how easy it is to put volume inside the lung. So if you need this pressure to inflate the lung, that's a high compliance. And the resistance is, what is the resistance to the gas flow? Is it easy for the gas to flow inside, or it's difficult for the gas to flow inside the lung? A trigger means how the ventilator, when the ventilator allows the patient to inhale by himself, means it's not the ventilator which is giving the patient breath, it's allowing the patient to inhale by himself, or at least to start the breath. So when the ventilator feels like the patient is trying to inhale, it's going to allow him to take that breath. So this is kind of trigger, means the patient is triggering that. EST is expiratory trigger sensitivity. That's at the expiration phase, when the ventilator is going to stop the exhalation and starts new ventilation stroke. That's the point of the ETS. So these are the ventilation parameters that, as you see them on the ventilator, so that's the pressure curve that you can see. That's absolutely, that's the PEEP, okay? Where when the patient exhales, he doesn't empty completely his lung. He stops at some point. That's the PIP pressure. That's the flow waveform. That's the inhalation, and that's the exhalation, okay? And as you can see here, the pressure doesn't go to the negative part of the graph, because, as we said, we are not pulling gas from the patient, we are just pushing gas inside the patient lung. So that's the pressure, that's the volume waveform. So that's obviously the inhalation, that's the exhalation. Here, this is the TI, which is the inspiratory time. That's the TE, which is the expiratory time. The time that the patient is using to exhale. Work of breathing is very important. Work of breathing means the effort or the force that the ventilator is generating to force the pressure go inside the patient lung. So if you can imagine, this is the ventilator is pushing gas inside the patient lung. What's gonna cause the gas flow inside? Of course, there is a pressure difference that's allowing the gas to flow inside the patient lung. This pressure difference is calculated using this formula. So there are different factors inside and outside affecting the pressure and the gas flow. We have, for example, the muscle pressure, which is resisting the gas flow. We have the ventilatory pressure here. We have the elastic coil pressure of the lung itself, how compliant, how stiff is the lung, how much flexibility is the lung towards pushing or filling gas inside that lung. Of course, plus the flow resistance, how much resistance we have here, resistance to the flow. So we have two parts of the equation. We have the muscle pressure and the ventilator pressure pushing gas inside, and we have the elastic coil and resistance pushing gas outside. So in order to allow the gas flow inside the patient lung, this part needs to be higher than this part to allow so if, for example, you have a lung with, or you have airways with high resistance, so definitely you need to increase the ventilatory pressure. If you have a ventilator with high recoil elasticity, means also we need to apply higher pressure to overcome this part of the equation. So this is kind of also explaining the formula, the pressure difference between and here, because this is it's all around. It's all around the pressure differences here and here, and how much pressure you need from this side to apply it inside the other side. So it's all around understanding these parameters to know how much pressure you need to give or apply to that patient. Breath phases, we have, as we have seen now, the waveform, we have the inspiration and we have the expiration. So we are talking about mainly 4 phases: end of expiration and beginning of inspiration, and then delivery of the inspiration, end of the inspiration, and beginning of the expiration, and then the expiration phase itself. These are the main 4 phases of the and then we're talking about triggering, cycling. Like triggering means when you are going to start the breath, what is going to trigger the beginning of the inhalation. Cycling means what is going to end the whole breathing cycle, which factor is going to end the expiration. Sometimes it's a patient factor, means the patient himself decides that I want to end here and start another breath, another stroke. Sometimes it is a sitting factor. Flow factor means when you reach a minimum amount of flow during exhalation, the ventilator knows that this is the time to end the exhalation and start another breath. Sometimes it's time cycled, means you have, for example, 2 seconds to exhale for the patient to exhale. So when the 2 seconds finish, the ventilator knows that this is the time to end the exhalation and start the inhalation. So different parameters can control the cycling, means when to end the exhalation and start the inhalation. We have 2 types of breaths, major types of breath. One is called mandatory breath and one is called spontaneous breath. What do we mean by mandatory breath? Mandatory breath means it is delivered by the ventilator. It's as simple as that. Spontaneous means this breath is taken by the patient. So even if the patient is on the ventilator, sometimes the ventilator is allowing him to breathe by his own. If the patient breathes by his own, that's called spontaneous breath. If the ventilator is giving that breath, that inspiration breath to the patient, that's a mandatory breath. Okay. The mandatory breath, by the way, can be triggered by the patient or can be triggered by the ventilator. As I said, sometimes the ventilator tries to inhale by himself. The ventilator allows him to start, but then the ventilator gives him the total stroke, gives him the set amount of pressure or flow. This means that it's a mandatory breath. Even though the patient has started this breath, it's still a mandatory breath. So spontaneous means the patient has started the breath and the patient has taken the full stroke by himself. The ventilator didn't deliver him the set amount of volume or pressure. Okay, so this is help us understand whether this breath is spontaneous or mandatory. For example, does the patient make inspiratory offer? If yes, this doesn't mean it is spontaneous. Still, we need to ask another question. Is the breath cycled by the preset ventilator settings? If it's yes, then the breath is mandatory because, as I said, even though the patient has started the breath, the ventilator has given him the full stroke. But if the patient has started the breath and the patient has taken the breath by his own, that's a spontaneous breath. Okay. Assisted breath means sometimes it is spontaneous, but the ventilator is giving him what we call pressure support, means supporting him with that breath, but it's not giving him a full stroke or a full breath. Mandatory preset. Mandatory means I'm setting a parameter. I need to give the patient tidal volume of 500 ml. The ventilator is going to give him the 500 ml. That's a mandatory breath. Okay. Control variables. We have volume, pressure, and that's the last slide because I think we have reached the end of the time here. So volume means it is my set value that I need to deliver to the patient. Sometimes I say, okay, I need to deliver to the patient 500 ml of tidal volume. So that's a volume control. Sometimes it's a pressure control, means I tell the ventilator, I want to deliver to the patient 30 millibar of pressure, for example. So that's a pressure control. Flow control, it's neither volume nor flow, no pressure. It's a flow control, means in the settings, I tell the ventilator, I want to give to the patient, for example, 60 liter per minute of flow. So that's a flow setting parameter. So I either set the volume as a mandatory parameter for the patient. Sometimes I set a pressure, sometimes I set a flow, right? So I think I need to stop here for you if you have any questions.
Thank you very much, Malik. It seems like there's been one or two questions. Just a reminder for everybody, if you've got any questions up to now, please post them in the text box and then we can take it from there. So first question, what could cause airway resistance from Luvo? What could cause airway resistance?
That's a good question. Thank you so much. Sometimes the most reason for that is the secretions inside the patient airways. When there is a lot of secretions inside the patient airways, that causes the resistance. So the solution here is simply to make the suctioning. You suction these sections from the patient airways, caused mainly by inflation. Sometimes that causes more secretions. Yeah.
I think the next question is related to that. So, when you do insert an ET tube, doesn't that overcome or mitigate the airway risk or the resistance? So, if you do place an ET tube, properly down, does that not assist in the resistance of the airway?
It will minimize, of course, but you are putting the patient, the trachea until the end of the trachea, but there is also the lung airways as well inside. So of course, we can't put the intratracheal tube inside the lung airways.
Yes.
Exactly, yeah.
Okay, here's another one here. How long does it take the body to breathe natural again after being ventilated? With reference to the muscle damage that you refer to. So let's say somebody's been on a ventilator for 5 days. How long will it take for recovery?
It could take days, it could take months as well, depending on the ability of the lung to respond to the treatment. And talking about that, there is what we call the recruitability assessment. Means, is the lung capable of inflation and deflation? Because some lungs are stiff lungs, very stiff. Fibrobtic lungs means they don't have the ability of that inflation and deflation. Sometimes some parts of the lung are functioning, other parts are not functioning. So it all depends on the severity of the case of that patient. It could be days, it could be months.
And thank you. I don't see any other questions. Okay, I think that's about it. Then we can wrap it up. We have recorded this with Malik's blessing, and we will have it available on the KISA website for anybody that would like to revert back to this afterwards. Thank you very much, everybody, for joining in, and enjoy the rest of your afternoon. Thank you very much, Malik. We really appreciate your time. Thank you.
Thank you very much for all of you. Thank you so much. Have a good day.